Welcome to Health Tech Heroes, where we talk to innovators who are rewriting the DNA of healthcare. Today, Lyle Mioduszewski, the president and co-founder of Perfecting Peds. With years of experience as a nurse, a passion for healthcare reform, and a commitment to optimizing pediatric therapies, Lyle is reshaping how we provide care to the youngest among us. His journey from frontline care to leadership epitomizes dedication to improving lives over innovation. In this episode, we will delve into Lyle's inspiring story, his trailblazing company, Perfecting Peds, and his vision for the future of healthcare. Welcome to Health Tech Heroes, Lyle.
Thanks, I'm so excited to be here and chat with you.
I'm so glad you are here, and I want to warn myself, it is going to be a lot of on children's health and always very emotional. And in our pre-conversation, we did discuss that it's always the why that you discuss with your team. You are always thinking about the why, then what and how, and that's very important for any company. For your company, it is just absolutely 100% essential. And I remember that conversation very distinctly with you, Lyle.
Yeah, it's hard not to have a business that we do in care delivery with the population that we serve without thinking about the why on a daily basis. And the why seems to be amplified every day that goes by on this journey. So our team is constantly sharing patient stories, just even within our team's chat in real time about what happened that day, what kind of feedback we got from a parent or a patient. And in the hard times, it absolutely keeps every one of us going. The feedback loop is really great. And our why it's in front of us, multiple patients at any given time throughout the day.
Thank you very much for that, Lyle. Can you share your personal journey? What sparked your passion for healthcare and ultimately led to the establishment of Perfecting Peds?
Yeah, I hate talking about myself. I will do my best here, but to make it concise, just for me personally, it started as a kid. My mom is kind of the reason. And so she managed a rheumatology office for about 35 years, including when raising me. She'd take me to work with her and I'd just watch her interact with patients. And at the time, I don't even know that this was a term, but she would help them navigate their own healthcare, whether that was their insurance, the appointment that they had that day, the follow-up, their medications, whatever it might be. And I saw that brought her joy, and I saw the effect that it had on the patients. And I just think about like the way that I consume healthcare today for myself and my family. It's kind of difficult to get a good feeling when you leave the doctor's office. Some are great at it and a lot are not. It's a tough job. And so I think that was really the entry point for me to know that I wanted to help people in kind of a moment of weakness for the average layperson. You're so beholden to what your provider or that person at the front desk has in store for you. The better you can make that experience and the more helpful you can be. Geez, if you're into that kind of the thing, when you clock out at the end of the day, it's a good feeling. I always joke, I went into the ER. That's where I started working first. And the reason is funny. My mom, again, would watch this show when I was growing up on the Learning Channel. It was called Trauma Life in the ER. And it's real footage of patient cases. It's not on anymore. I wish they would bring it back because it was raw. I love the TV dramas out there. After I got into healthcare, I stopped watching the ER shows and whatnot. But that show was real. And I think it presented an opportunity to see what it looks like to help people in a similar way in a moment of absolute crisis and potentially trauma, depending on what the situation was. Long story short, I got really fortunate in high school, and we had a cooperative program where kids that were interested in certain domains could leave school halfway through the day. I would leave and go to the hospital my last 2 years of high school and work directly in the emergency department as a nursing assistant and kind of an ER tech. And that experience was profound for me. I still think back to individual patient cases and remember patient names over 20 years later. And it's funny, the first day, there were two of us that were lucky enough to be able to get the emergency department as our assignment, right? The hospital has med-surg floors, and some people got sent to the rehab unit. And they were just trying to send high school students for the first time into the ER. And so I raised my hand pretty enthusiastically along with another young girl. And our first day, we did all the things, including CPR. And she didn't come back the next day, my counterpart. And I came back and I was like, how can I do this more? It was an immediate love. And not just this, actually terribly sad CPR story, but helping people physically and emotionally and being there for people in usually a really difficult time. And those situations look different, and it's different from each room to each room, and maybe a little bit predictive of this short attention span that I might have or had at one point. And so that was kind of the entry into this world. I became a nurse. I got really fortunate, was able to study in the Caribbean in a developing country for half of my education, then finish at Purdue University. And then the journey kind of evolved as a typical nurse would in acute care, and really just focused on care delivery and the patient for the first 10 years of my my healthcare career.
Yeah, I mean, that's a fascinating story. And high school students in an ER, that's almost can be traumatic, right? How did you manage that? I mean, and you went and raised your hand for the second time that I want to do more of this. What kind of mindset was required at that time? Was it more to do with helping, or did you enjoy the challenge more? What was that drove you to raise your hand again?
Yeah, it's not many people have asked me that question, but it's a question I ask. The older I get, the more I question if that was too early. I think at the point in time it was adrenaline. You know, they call a lot of people who choose to work in emergency care, whether that's in the field as a medic or a firefighter or a law enforcement as adrenaline junkies. And I think the same goes for the people who choose to do that right in the emergency department. You're signing up for, catastrophe and a lot of compartmentalization, literally minute to minute, maybe without knowing it. And I don't know that I knew exactly what I was getting into. And again, I still think back and question if it was the healthiest choice. And I know for most it probably isn't, right? And so by default, I think I really had to develop this ability to compartmentalize, go back into my high school classes and converse with my friends, maybe telling them a little bit about what I saw, but most of it they wouldn't be able to handle or want to hear. And so I would leave it at the door somehow as a child, 16 years old, and not let it really affect the rest of my day. And I don't know, maybe I was just kind of I was built for that at that point in my life. I don't know if I am anymore, but
Okay, at that time, this is probably one of the cases, if it doesn't kill you, makes you stronger, right? So you probably came out stronger and keep your head focused and not get distracted by the noise going around you. I mean, I was just thinking about a high school kid in an emergency room.
Fasa, I think that the thing that comes out of that, and there's many children that are in a similar program, maybe not in the ER, but still you work anywhere in an acute care setting, you're going to be exposed to things that you would not normally be exposed to, especially at that age. I think the main thing that it taught me is we are all so different, really empathy, right? And to be able to try to put yourself in that person's shoes, regardless of why they got to the place that they did in their head and the way that they think and in their life, their perspective is unique. To be able to work with that person, try to carry them forward, do the right thing, really just focusing on the health outcomes and the best possible outcome for that individual was, the upside of doing sometimes some not so fun.
Perfect. On your LinkedIn, you have highlighted that you're a dad, you're a husband, and thalassophile, what it means to you. And can you tell us more about your personal side, how it influences your professional life and outlook in general on life?
Yeah, for sure. I mean, to the end of that question, it's pretty straightforward. It's just a love of water, an obsession with water and the ocean. So for leisure activities, my wife and kids and I love to go to the beach. We like to go boating, fishing, anything we can do to get out in the sun and enjoy the water. It's motivated us to move from Michigan, where we were all freshwater, down to Southwest Florida about a year ago. And so we're kind of living out that dream as we speak. It's been really nice. Fatherhood and being a husband, I think anybody can say this, it changes your perspective on so many things. Just like the roles that we're talking about in healthcare delivery, those jobs are really hard too. And so as I think now in the role with Perfecting Peds, I'm constantly thinking about the perspective that our patients and their caregivers have, and the ultimate responsibility that they have over ensuring the best health outcomes for their kids and those that they care for. And so it's very mixed together, right? So when I hear a story here at work, or we're evaluating what we might be doing with the patient or not doing, the perspective is always rooting back to, if this was my kid, and if you don't do this, I think a lot of people do. When we go to the doctor, we say, if it's pediatrician, you're going to a pediatric office. Much of the time, my question is, well, great information, I've got enough to make a decision here, but I'm really here a lot for your opinion, doc. And what would you do if this was your kid? I think that's a question we ask a lot. And people put a lot of trust in that. So shapes nearly everything after the fact, right? I'll also say huge kudos to people in care delivery who have had kids and then continue to do that job, because you see your kids in each of those patients, and sometimes that's a really hard thing to do.
You have Perfecting Peds optimizes pediatric therapies by integrating pediatric pharmacists. Can you walk us through the key services and goals that make your company unique?
Yeah, so we're a pioneering, trailblazing, one-of-a-kind company. Most people are not familiar with what a pediatric clinical pharmacist is. I wasn't before I met our co-founder and CEO, who is a pediatric clinical pharmacist. But we're taking care of a very straightforward problem before we kind of talk about the solution, and that is pediatric prescriptions and pediatric pharmacotherapies aren't as straightforward as adults. Most of the research and development in this country goes towards what makes the most money, and that's adult medicine. We see that the majority of pediatric prescriptions are written for off-label indications. Due to the limited nature of education in pediatric pharmacology, especially at the dispensing point of the pharmacy, and with a typical community pharmacist is a point where we think we could do better. And even at the point of prescribing, so most people don't know that most of pediatric prescriptions are weight dose based, meaning, a kid's weight can, just a small change, and we know how fast kids develop. The younger you are, the faster you're developing, can change in a period of days, weeks, months. We're dosing based on that information. It's a really critical element. I think most parents will agree that if they've received a prescription from a pediatrician or an urgent care or an ER, you probably haven't seen your child's weight on that prescription. And so in effect, the dispensing pharmacy or local community pharmacy, there's not a lot of checking that's going on against the indication for that prescription. Is it optimized to the disease states, kind of the pathophysiology or the metabolism that individual has, and all of the other medications that are on the profile? And so, the same issue of polypharmacy that we see in adults and geriatrics is wildly prevalent in pediatrics, and we're just not really talking about it. Another part of this is, it's a good problem. We're keeping people alive longer than we ever have before. We're treating diseases that we didn't used to be able to treat. There's congenital abnormalities that had, very limited life expectancies, and now we're keeping them alive for years and decades. And so there's just so much out there to be able to keep up with that information and then coordinate it across all the other things that are going on in the healthcare delivery of somebody who's high risk for medically complex, which is where we focus, is difficult. And we think that those instances where I'm talking about kids that are on 3, 5, 10, 20, 30 medications at a time, their specific stage in development and growth, and their unique situations of comorbidities and disease states really makes each of them an N of one in the world. And we need to kind of treat them individually and evaluate them individually. And so our kind of founding story is we have an expert that does this, that's educated in a post-baccalaureate program, gets their doctorate. In our company and in what we're doing, they go on beyond that and get residency trained in a hospital for a couple of years in pediatric pharmacology, and then board certified in the practice. That profession is about 25 years old. It's probably older than that in all regards, and we do know some pharmacists that have been specialized in thinking about it that way, but really like a residency trained program approach to it. And these pharmacists have been all reactive, sitting in hospitals, children's hospitals, academic centers, waiting for kids to get sick and then come in, and they're part of the care team that a lot of people don't see behind the scenes. So my child has an illness or an injury and they end up in the hospital. There's a multidisciplinary care team that takes a look at that patient, the doctor diagnoses, and then we come together on what are the right therapies for that person kind of in real time. After you're discharged from the hospital, that specialist that's kind of looking at pharmacotherapies and organizing things, that service stops as soon as you leave the door. And then it's really it's on the mind of your primary care pediatrician. And you know what kind of time that they have with you and their ability to navigate and, keep it a very large group, a large census of patients, patient panel, controlled and organized. And when there's complexity and medical complexity and the things that we're looking at, they can use the hub. I think they'll all tell you that. And so the idea here is less than 1% of all pharmacists have pediatric training. There's about 1,500 board certified pediatric pharmacologists in the country. we're taking them and putting them onto the care team of high risk and medically complex patients longitudinally. And sticking with them from the point of us getting onto their care team until they transition into adulthood and into adult medicine and up to about the age of 24.
So let me get this right. Effectively, not only we are static in how we have been, unless we do some trailblazing work like Pediatric Peds is doing, we are literally for the large part we are static how we treat. We are not innovating as much as we need to. And the second part is also the issue is getting more and more complex because we are solving the initial part, improving the life expectancy. So not only that we are generally static, we are also, the diseases are getting more and more complex. So it is a double layer problems that we can solve with a targeted options like you have. So what would a patient, like say a person who brings their child, and what would be the difference they have the help of the pediatric peds, and another patient same profile does not have pediatric peds? Can you contrast these two situations and tell me why one is better than the other?
So yeah, the patient that has our service has someone that is one there to educate them as they come onto therapies, or when we first enter a patient's case, can go through their therapies, ensuring asking and answering the first question: is this medication or are these medications helping you? Is this the right therapy for you to be on? And then we kind of go down this cascade of things like, are your drugs safe? Are they interacting with each other or causing any side effects that might be labeled as a diagnosis? Maybe nobody even knows about them. Are there medications on the profile that might not need to be there? So we see a lot of polypharmacy where side effects of medications are combated with other medications and then left on the profile for years. And give it 4, 5, 6 years. Sometimes the provider's changed out, the original prescriber's not even on the case anymore, and no one knows why the child's taking a certain medication or a string of medications. And so we'll do the discovery and the investigation to understand exactly why the patient is on each medication, ensure that that's the best medication for them. And then if it's not, rooting out what are the other types of medications that might be available or non-medication interventions. When we do this on kids that are on typically more than 5 meds at a time, our intervention rate is 13 per child. And so we're looking at things like, what are the serum blood levels of those drugs, or what are the serum blood levels of the metabolism markers that metabolize those drugs, or really anything around them, just to ensure that things look right. So the patient that doesn't have that, they're out there just taking their medications, right? There's monitors that should be in place for each medication that you're on. So certain psychotropic medications require you to get an annual EKG. Make sure that the rhythm of your heart looks good with the drug, because some of them prolong some of the electrical signals in the heart, for an example. I'm not saying that a patient that doesn't have our service isn't getting that type of monitoring, but there's a chance that they're not, and we're an added layer of protection to make sure that that kind of stuff is happening. Another component is just time. Like, we have time. If you think about your typical doctor's appointment, they're really in a boxed model that's set by a reimbursement fee schedule for the most part. Most pediatrics are operating in fee-for-service today. Their reimbursement models are set by government and private payers. And they've got to fit a certain number of patients to be able to pay their bills into a certain amount of time. And so if you can imagine having a new diagnosis, going to the doctor, being prescribed a new therapy, and only having a couple minutes to talk about the why you're on it, what to look out for, how it's going to help me, and then what we do later, it's a really short amount of time. And so when we work with patients, we ensure with their insurance company that we have lots of time. The initial appointment that we spend with them is an hour on camera, just like this, looking at them administering drugs. If you don't have a kid with medical complexity, a lot of these drugs are done via syringe. A lot of times they're reconstituting the concentration of drugs and diluting them and drawing them up into syringes. There's a lot of room for error. There's a lot of room for error in what you do after you administer the drug. So we'll watch them do it. We'll have them pull the rescue medications for things like aborting seizures out of the cupboard and read the expiration date to us to make sure that they've got drugs that are going to work. A lot of times they're expired. So This added layer of protection on the front end, and then us coordinating on the back end. So we'll look at convenience. How many times is a family going to the pharmacy per month? Are the medications being dispensed all at once or throughout a long period of time? How can we make that more convenient to drive adherence and then just build confidence in what the patient's on?
Man, this is a huge help for the parents. Just that extra layer of security, knowing that you're doing the right thing and the best thing for your child. The question arises, how do the patients get on your program? Who pays for it?
Well, I'm going to tell you a story on how we got here, and I'll make it succinct, but the realization was a lot of patients were ending up in the hospital, and the clinical pharmacist was spending a ton of time fixing or helping or mitigating problems with the medication regimen from the outpatient setting. And so we implemented the first deployment of the service into a skilled nursing facility that housed medically complex kids. We charged them directly, and they had to have a pharmacist on staff there, but we went a little bit above and beyond just to kind of prove out this model. The realization was, after completing this, it was very beneficial. We had reduced admissions from the skilled nursing facility to the hospital by 44%. We had de-prescribed 15% of the medications on the profiles that were unnecessary. Again, intervened about 13 times per kid. And there's an economical impact to that. And who was the beneficiary of that savings? The insurance company that had the risk over the life in the facility. Two ahas there were, one, if we're going to take the service out, and expand it, most of these patients aren't living in facilities, they're at home. Very few are in under care 24/7, 365 days a year. And two, the person that's going to pay for it is the one that's realizing the financial benefit. And so we started to take it to insurance companies, healthcare insurance companies, and say, you are mandated to do this work in geriatric populations. Medicare beneficiaries are required to have a benefit called medication therapy management when they kind of look like the patients that we help here at Perfecting Peds. We think that you should do this for pediatrics as well. And so their overwhelming response has been yes, and kind of where have you been? And so today we contract directly with health plans in a way that, one, doesn't require the patient to pay anything. So we don't do anything that has a copay co-insurance, doesn't affect an out-of-pocket, deductible out-of-pocket maximum. It has to be completely paid for by the health plan. And then we start outreach and trying to enroll families and patients into the service by way of their health plan. We do offer a private pay option for families that might be in a state or underneath a healthcare insurance plan that we're not contracted with, but we're growing pretty quickly.
Oh, that's awesome. And I was hoping for some model like that where patients don't have to pay for it, and looks like you have even taken care of the copay. You have really deeply thought about this and not affecting their deductible. Truly, bottom of my heart, appreciate that fact that you're doing that. And you did mention 31% of pediatric prescriptions contain errors, and you did give me two metrics: 44% reduction in hospitalization and 50% reduction in medication. Or how about, did you manage to, what is the percentage of errors did you manage to reduce in prescription? Do you have any metrics on that?
I don't have a direct metric to what was fixed on the prescription, but I can give you some metrics around what a typical program looks like for us and the number of interventions, because not everything we do is fixing an error on a prescription. So again, it might be in the education of the parent. It could be helping with access to that medication because of financial reasons or prior authorizations that are getting denied, or there's a slew of things that we would do that wouldn't be classified as that. But what I can tell you is when we're doing this at scale, so we launched a health plan in January of this year. It started out with 1,900 patients, all issued on January 11th. And so in the first 4 months, we took a look at the first 565 patients that we enrolled into the service and got engaged into the program. And I'm going to give you round numbers. It's not exact, but we had elicited 7,000 problems on they're called drug therapy problems, acronized as DTPs. And so you have drug therapy problems and drug therapy resolutions. Some of those are errors right off of the script. Something wasn't dosed appropriately for the indication.